Okay, fantastic. We are live. Hello, everyone. Welcome to this all-important panel discussion, COVID-19, African Road to Recovery, with our wonderful speakers and moderator. My name is Jonathan, and I'm a speakers and content coordinator for the organizing team behind the LSE Africa Summit. I want to quickly remind all our different attendees and participants to use the hashtag LSE Africa Summit 21 across different platforms to follow the event. And I'll quickly hereby introduce our moderator before handing the floor to him. Mohammed-Anwar Sadat Adam is an Atlantic Fellow for Social and Economic Equity and an interdisciplinary development professional with 15 years of experience in strategy and program leadership, in organizational development for civil society and local government, in gender, governance, and social accountability, as well as development evaluation. This is all, of course, in Ghana and beyond in the continent. So warm welcome to you, Sadat. And we're looking forward to all the speakers that you'll be introducing as well.
Thank you, Jonathan, and welcome to everyone. I hope you can hear me okay. It is an honor to be part of this great summit. And if you give me opportunity also to just introduce our distinguished speakers for this particular session. We are happy and privileged to have people who have both academic and research background, and the people who are, I'll call the innovators and the entrepreneurs in the field who are here to share with us their vast experience related to the topic for this session. We are privileged to have with us Dr. Ola Brown, who is the founder of the Flying Doctors Healthcare Investment Group. She's not just a founder of group, she's also love writing, and she has already published about 4 books covering different range of issues, focusing in the health sector, health policy, banking, financing, economics, to name just a few. We are also privileged to have Dr. Abasi. Dr. Abasi, if I did not pronounce your name very well, pardon me, but it's quite familiar to my former lecturer's name here in Ghana. Dr. Abasi is the founder and chief executive officer of 54Gene, a health technology innovation company based in Africa, helping to do a lot of work in terms of looking at the dynamics in the health sector, but also helping us to come up with innovations that we can take care in addressing health challenges in Africa. We are also happy and lucky to have with us Dr. Lucy Kanya, who is an assistant professorial research fellow at the LSE Department of Health Policy. Research area includes health economics, care financing in low and middle income countries, as well as the role of the private sector in this enterprise. So you can see that we have a vast array of people with have experience and expertise and exposure on the continent of Africa to help us in taking forward the discussion for today. So you are most welcome to our speakers and welcome to our participants who are at the backstage and are with us this morning. To start off the conversation, I have been thinking about this particular session theme, which is COVID, the African Road Recovery. And 1 year into this pandemic, essentially, we have seen quite a lot of things that the pandemic has done to us in Africa by exposing many of the common inequalities that we have in our societies, ranging from education, health, welfare systems, to even the capacities of countries to respond to this pandemic. In this 1 year, a lot of things have happened. And so I'll start off by inviting our speakers, first to Dr. Lucy Kanya, to share with us what have we learned or what are we learning from Africa's response and recovery to this pandemic 1 year on. Over to you, Dr. Lucy.
Thank you very much, Sadat, and Thank you to our speakers, my fellow speakers. It's going to be a real treat for me to hear from you. And of course, welcome to the audience. And today, I mean, just like Sadat said, we are looking to learning from the audience as well. So it's not just us. We are hoping to hear from you. So I would just start by, giving us a bit of perspective. I know we already know, but I think there's no harm in repeating this, that we are talking about a continent with 1.3 billion people, home to 16.7% of the total world population, and a combined GDP of approximately $2.6 trillion. And like all other continents, Africa has suffered the twin health and economic effect of the pandemic. We have more than 4.1 million cases, and close to 110,000 deaths. But, just in perspective here, this accounts for 3.3% of the known COVID cases worldwide and 4.4% of related deaths worldwide. So that's where we're coming from. Some regions, obviously, within the continent have been hit more than others. And as far as the economy is concerned, the Ghana finance minister recently said something very interesting. He said Africa is going to lose a decade if nothing is done to respond to the pandemic shock. But having said that, response to the pandemic was influenced by a lifetime of dealing with similar emergencies and impossible situations, as we all know, and all this in an environment of very limited resources. We have the benefit of that experience and also technical know-how to apply context-appropriate solutions in addressing these things. And for me, it's necessary to emphasize from the beginning here that we are thinking about context-appropriate, because Africa is not homogeneous. It's not a country. And even within individual countries, there is great diversity. So the impact of the pandemic, the response, and the recovery process have all been different, and they will continue to differ. But we also have some similarities, and we should learn to play our strengths, to play out the strengths that we have, rather than be dragged in, as we have seen, into some global response patterns, which sometimes do not apply to our context. But I would also love to say that, Africa's economic and health problems did not start with the pandemic. So the pandemic has just exposed the cracks in our health system and the cracks in our economy as well. But despite this, some core lessons. One, we should trust our homegrown solutions. There's still memories that we have built on the proven and context-specific solutions that we have used in the past to address Ebola. We have used this to address other pandemics, other diseases that were really affecting the continent. And some lesson on emergency preparedness as well. We need to critically appraise where we are coming from, appraise our response to those past experiences, and adapt for the current situation. And countries that have done that, and especially in some countries in Western Africa, where Ola and Abasi know better, countries that are affected in that region by Ebola, for example, they were kind of prepared in a way. They knew what to do. They could draw on that institutional memory, and they hit the ground immediately. But also just resist the lure of the funded, popularly themed, low-cost, high-impact interventions to address this pandemic. So for me, I think we need to prioritize based on the needs of individual countries. Actually, our greatest loss in this pandemic has not been to COVID. It's been due to excess deaths from other pre-existing things that we neglected in the COVID-19 frenzy. And I'm not trying to belittle COVID-19 here. For example, over this past 12-month period, while COVID has led to the loss of approximately only about 2,000 people in Kenya, and I say that with all due respect, we have lost 30,655 people to diarrheal diseases. I think this is unacceptable, diarrheal diseases while we are focusing on a pandemic. It exposes the health system issues, but also I think it's time for us to just think about our priorities. We lost people to malaria, 10,000 to malaria, 10,000 mothers, to birth trauma, to things that we could deal with. So also think about safety nets. And I'm sure my colleagues will pick on this. Safety nets for the poor and vulnerable. We don't, by applying these blanket responses like lockdown, we're not thinking about the fact that we do not have safety nets for our people. And other things like, thinking about the gender lens. It's women and children that are bearing the brunt of this in low and middle income countries, and especially in Africa. And the people, the community. I know people are talking about vaccines now. It's an area I don't really want to go into. But, why do we have resistance? Because we're not involved in the locals, the citizens. People are not being involved. But then consider the reality of all of this and our extreme resource constraints. So we really need community-based solutions, which will have greater impact anyway than focusing on hospital-based ones. For example, we're talking about ventilators. They are important, but ultimately it is the community-based solutions. Ventilators will be very expensive, and in the short run, we don't have the fiscal spaces like in many parts of the continent to quickly mobilize ventilators. But how about local solutions? How about community-based solutions? And then just related to that, lastly, for me, Africa needs to keep writing their story. We need to keep writing our stories as based on our lived experiences and as we perceive this and our interactions with the system, and use this to shape our responses. Thank you.
Thank you very much, Dr. Lucy, for that very encompassing introductory remarks from the economics to issues about our health system, but also bringing some experiences that some African countries brought to bear into Ebola in managing the pandemic. At this point, I would like to invite Dr. Abasi to take the stage for 5 minutes, and then Dr. Brown will come in after Dr. Abasi. Thank you.
Thank you so much, Sadat, and you got my name right the first time, that time. So I happened to be in Nigeria when the COVID pandemic happened. And I do have to say that, Africa responded better than expected. And that was due to innovative and talented individuals that, are currently in Africa. For the first time, or for one of the first times, you could see that there was collaboration between the private sector and public sector. And in many countries, I would say that the private sector almost bailed out, if not bailed out, the public sector. And it was beautiful to watch how, everyone, wanted to be part of the solution. And that led to quite a lot of innovation. But one of the things that I think, this has also done is that it's opened us up to major infrastructural issues, an ecosystem type issue that exists in Africa, because an innovation is just an innovation. What makes an innovation thrive, or what creates the ability to spur multiple innovations, is when you have the right ecosystem, supporting the people who are making those innovations. I mean, we can talk from the fact that you see, because of poor infrastructure and some of the issues which I'll be mentioning, we've lost a lot of talent in Africa. But we do and we're proud to see that, we still have talent within Africa. And, why is it that our talent, when they work in areas where the ecosystem works, they thrive. It's like a plant, that has the right soil conditions, has the right, nutrients. And I think that's what we need to begin to do in Africa as well. And if the COVID pandemic has taught us anything, that's, I think, one of the things it has taught us. We've seen, for example, educational challenges. I was in Nigeria when, like I mentioned, when COVID pandemic started. And to do a PCR test was very hard. And Ola can bear witness for the majority of people in the country. And why is that? It's because most of the students that have studied molecular medicine or molecular sciences have not had the right types of lab infrastructure to actually learn the practicals. I mean, not too long ago, I was in the same boat. I did Bachelor's of Sciences in Nigeria. And I remember when I went to do my master's at Imperial, and the first time I got to a lab, I couldn't actually use a pipetto. It was so embarrassing. I mean, I knew all these things in my head, but I know how to apply them. And so and it was very embarrassing. I had to learn using YouTube videos in the class because everybody else was ahead. But give me some time. I was able to catch up, and I even finished my PhD in 2 years, right? And that was, again, because you have that supporting system. And so what we saw was, poor education. We had to come in, Ola's team, my team. We trained quite a few scientists or students, graduates, on PCR techniques and molecular medicine techniques. we need to start talking about how we bring back funding into our universities and how we make sure that the right types of skill sets are being taught right now. The same thing happened in the healthcare system. Most African countries have not funded healthcare for ages, like the same amount of money they were funding healthcare with in the 1990s is the same exact amount of money, without considering that there's been inflation, that the value of the currencies, local currencies, have fallen. How do you expect to keep healthcare, working for the populace? So we saw that, and we saw private individuals come in to set up hospitals and isolation centers. We hope that, we can have that cross-sectoral collaboration where you have bankers and, other people in areas that are not healthcare begin to think about how do we invest in improving healthcare. We saw the existence of poor policies. Poor policies has been what has led to most of all of what we've seen. But again, we happen to see some very, very sharp, talented people. People came in, people who everybody wanted to play a role. And, together, we put our heads together to try to solve these problems. There is one other area that lacks, that Africa has never really gotten right, and I hope begin to change, and that's investment in R&D. We see, lots of countries coming up with vaccines and tests and what have you, but we don't have any of those because we have never really prioritized research and development, and we haven't funded that. There was also the occurrence of, Africa is a black continent when it comes to data, right? Lack of data. How do you really know what to do? I hope that one thing the COVID pandemic has shown us is how important data is, because, there was a need to report. There was a need to show what you are doing. We need to start making sure that we don't see data as a bad thing. Data is a good thing. It's a good tool. It improves businesses, improves policies. Of course, managing and monitoring and regulating data is very important, but, you still need to be able to use it. A few other issues like also even strengthening our regulators. Suddenly, you had all this new PCR tests coming out, or drugs for that were being repurposed for to COVID, or even new therapies for COVID. And some of our regulators, the FDA equivalents in many countries, for the first time had to be on their toes because there was so much innovation coming in, and they needed the tools, and they still need the tools, to begin to frame how these things come in. And not just that, but even for, the local innovations. The problem with innovating in Africa, yes, you might have a great innovation, but if you don't have the right regulatory agencies and institutions actually regulating and monitoring how that product is developed, you're not going to get trust. And so nobody's going to use it. And so we need to see how all of these whole things make a whole. I mean, the report card is out. We are lucky that, COVID was not as bad as we all expected it would. We are also blessed and happy that our people and Africans rose up to the challenge, even with low resources, even with I was going to use a term Ola had used earlier, but I will use it right now. But we saw, that Africa has a lot of talent and there's a lot of promise. And it's for all of us here, whether you're the economist, you have the policy mindset, or you're the innovator, you have the scientific R&D expertise, or you're the business person. How do we all begin to take all of us and create a whole that benefits the continent going forward?
Thank you very much, Dr. Abasi. If I were in the room by now, I would be giving you a thunderous applause for that. Thank you. Shall we now invite Dr. Ola Brown to share with us her own experience and her perspectives on this particular issue? Thank you. And to our audience, please make use of the chat box. You can also send your questions, and hopefully very soon we'll open it up for Q&A after we have listened to Dr. Ola Brown. Dr. Brown, over to you.
Thank you, Dr. Lucy and Dr. Abasi. I mean, I think you've given a great synthesis of, the issues facing us in the post-COVID era in Africa. And actually, I'm not sure that I have that much to say, but when more to add. But when I think about healthcare in Africa, it reminds me of a trip that I took when I was about 24. I just started my company about a year before, and I was looking for financing. I was flying through America, and one of our billionaires in Nigeria asked me to come through to Miami because he wanted to make some introductions for me. And he said, this is how things need to be done. You need to stay in this kind of hotel, you need to, sit in this restaurant and invite investors to these restaurants. This is how, and he was like sort of giving me the billionaire standard of what I needed to do to attract investment. So the whole money that I took for the 5 days that I was staying in Miami, I finished within an hour. And then I had no money for the rest of the trip. And it was a really, really sad situation. And he had set a standard that really I could not meet up to because of my budget. And that's what I often think about healthcare in Africa, and something that Dr. Lucy talked about, which is homegrown solutions. I think a lot of the time in Africa, when we think about healthcare, we're chasing a moving target. The NHS spend on healthcare in the UK is $250 billion per year. So just like that billionaire in Miami, they tell us that this is the standard. They come here and say, okay, this is what you're meant to do. And this is the healthcare that you are supposed to see. But then they don't give us the money. And we want to aspire to that. We want exactly like what is in the UK. But we don't have the money and we get stuck, right? Because the healthcare budget in Nigeria is about $1 billion per year, roughly, federal budget. So if Boris Johnson actually came to Nigeria and gave us his health budget in a year, then it would take us for 250 years. And the money would have not finished in 250 years. So because you have an exponentially lower or fewer resources to work with, I think one thing that African governments have to think about is actually what is the standard of care that can be offered within that budget. And if we continue to allow, other countries to say this is the standard, but we don't have the money, then we're going to continually end up in the situation where I was in Miami, where you spend all the money that you're supposed to spend on different things, different issues. I had so many things to do, and I spent the money within 1 hour because at least he told me the standard, but he did not give me the money. The same thing I think applies in Nigeria. The total amount of oil that we make from money that we make from oil, even in a good year, is about roughly like $10 billion. So how is that going to take care of the needs 201 million people for healthcare, for education, for infrastructure, for paying back debt, for all the other things that we have to do, right? To the same standard of the UK or the US, bearing in mind that the US spends $20,000 per person on healthcare. The UK spends about $4,000 per person on healthcare. And basing it on the calculation of the federal budget, Nigeria spends $6 per person on healthcare. And you can say that there's issues of corruption and perhaps the money is not spent well, but still, when you have $1 billion to play with and another person has $250 billion to play with, and it's not even corruption, you just don't have the money. Nigeria does not make that kind of in the first place. Then you have to consider, okay, let's take a step back and think how we can do more with less. And I think that that's sort of the greatest lesson that African governments have been able to take away from the COVID pandemic. America and England and Europe spent a lot of money, but Africa actually was able to get results. And how did we get our results? By the old-fashioned things. Normal contact tracing with pen and paper. We did not have any app. We've done it before with Ebola. We've done it before with cholera. We've done it before with polio. These vaccination programs, actually, the WHO and the African CDC had developed capacity. So we're actually quite good at it, despite the fact that we didn't have to spend so much money to get the results. It was kind of the boring, low-tech things. that I think really got us the kind of results that we had from the COVID epidemic, which was a low number of COVID pandemic, which was a low number of deaths compared to the more developed countries. And let's not forget our demography. I can't discount that. The average age in Africa is like 19 compared to like Florida, where it's like closer to 50, right? So obviously there were going to be higher mortality rates, but we did a lot of really basic things that we've practiced over the years, and we got results from those things. So the answer isn't always more money. Sometimes it's how we use the money. And I think Dr. Abasi highlighted over and over again this importance of financing appropriately and appropriate innovative financing for our healthcare problems. But also making sure that we acknowledge that we do have certain budgetary constraints. And there's nothing wrong with being poor. Same thing in Miami. There was nothing wrong with me being poorer than him, to be honest. But my crime was spending as if I was rich. And there's nothing wrong with African countries being poor and not having the $250 billion or the trillions of dollars that America spends on healthcare. But the problem is when we begin to spend as if we are rich. So I think the rest of my points will be really highlighting some of the lessons that I think Africa has learned and some of the things that we need to consider going forward. And I think one of the things that it highlighted to all of Africa is the importance of healthcare across the board, right? I think policymakers in Africa previously, healthcare has been under-prioritized in favor of physical infrastructure, things like roads and bridges, and we have to develop our manufacturing capacity. All of those things are important. But I think, you know, every African policymaker, president, senator, congressperson across the continent kind of sat down during the COVID epidemic and realized, you know, without healthcare, we have nothing. And it's just as important as the physical infrastructure projects as an investment. And I think, secondly, I'll repeat Abasi's point about the role of the private sector, even more so, I think, in Africa than the rest of the world. I think in the rest of the world, if your earnings from tax, I mean, Nigeria only earns 6% of GDP tax. And you might say, okay, you know, the tax collectors are doing a really bad job, but actually 60% of Nigerians live in poverty. And, you know, it's very hard to tax people that haven't eaten. But money for healthcare that the UK uses healthcare comes from tax. And the tax to GDP ratio is about 30% compared to just 6% in Nigeria. So the governments obviously cannot get enough cash from so many poor people that have not eaten to be able to fund healthcare. Then they have to look to the private sector for innovation and also for the financing and the kind of public-private partnerships that can increase the fiscal space by bringing in private sector capital to complement what the private sector brings to the table to improve healthcare. And we did that across the board. I mean, Abasi we worked with on testing, capacity development, set up hospitals. We set up 2 hospitals in 2 different states. We had equipment sourcing from our bulk purchasing agreements from across the world. There were a lot of public-private partnerships across the board that used private sector efficiency, private sector capital, private sector expertise to deliver these healthcare solutions in collaboration with the public sector. And I think in the post-COVID era, we'll be seeing that a lot more. I think also one of the major lessons is a shift from tertiary care focus to primary care focus on healthcare. And I think this is another sort of interesting thing from my Miami trip. It's not only by paying $1,000 for a deal that I can take somebody out and get investment. You can achieve the same thing with a small drink, right? And we can achieve exactly the same result. But the standard that he was setting for me, I didn't say, look, this is my bed. And this is what I have to do all of these things. These 5 days, this is what I intend to spend. And I think that, you know, one of the lessons that came out from COVID is that primary healthcare is a lot cheaper than tertiary healthcare. It saves more lives, it's more cost effective. And the developed countries have a very tertiary care focused healthcare system. It's only when you're catastrophically ill that you go to tertiary care. But preventative care could be a cheaper focus for African governments going forward, African policymakers going forward, because now we've set our budget. We know what the budget is. So let's work within the budget to do the most amount of good for the most amount of people, rather than the older copy and paste approach that doesn't quite work. Then you run out of money in 1 hour. I think also one of the things that, really stuck out for me during the COVID epidemic, and one of the things that will be happening going forward, is the role of collaboration across the continent. The AU, the Afrexim Bank, the African CDC were very involved in the response across the continent. Afrexim from a financing point of view, the AU from a coordination point of view, the African CDC also from a response point of view. All of these Pan-African organizations really had a chance to sort of show how effective they could be, and they were in delivering care and coordinating purchase of vaccines, purchase of testing equipment, purchase of PPE, and distribution of those things across the continent. And I think we'll be seeing a lot more intra-African trade going forward, because the whole of West Africa's healthcare budget cannot add up to the UK's healthcare budget. And it's not because of corruption, it's because there's no money. As in, we are actually poorer. We don't make as much money. So when we bring in the corruption element and say that, it's because African politicians steal it all, no, that is not true. There's wastage in every system, and there are dodgy things happening in every system, including the American system. Because still, the American healthcare spends $20,000 per person on healthcare, and the NHS only spends $4,000 on healthcare, but the NHS gets better outcomes. So obviously, there are inefficiencies in every system, not just in African systems. But the biggest issue is just that we are poorer. And once you come to that acceptance, then you can start planning going forward about how best to use those resources. And I think there are things like reverse innovation. I think there are things that the West can definitely learn from Africa's response. I think that we can embrace task shifting. So using other healthcare professionals, pharmacists, biomedical scientists, community healthcare workers to do jobs previously or typically done by doctors, and that reduces the overall cost of the healthcare system, because the biggest source of spending in any healthcare system is personnel. So once you can cut that, you cut health costs drastically. And I think embracing technology, and Abasi is at the forefront of that, looking at the technologies that we can embrace, homegrown, in order to further reduce the cost of healthcare as well as improve its efficiency. And my last point is, I think, the greatest learning that has come from this whole episode and Africa's response is around the relationship between healthcare and economic growth. I think for the previous few decades, what policymakers thought was going to produce economic growth in Africa was, being self-sufficient in, rice or cement, or building this new bridge, or building a bigger airport. But I think people have come to realize good healthcare also has a big role in economic growth. The NHS is actually the fifth or sixth biggest employer in the entire world. If you look at every single American state, the highest number of people are employed in either healthcare or education. So healthcare is not a cost, but it's an investment, and an investment that we can't afford not to make in the economic growth and the progress, the development of our continent. Thank you.
Thank you. Thank you very much, Dr. Brown, for that brilliant remarks, building off from what has happened. At this stage, I want us to have a dialogue, and so I'm going to invite Jonathan. Jonathan, if you are with us, if there are some questions that are coming from our audience, general questions or specific questions to the speakers, so that we could take them at this point. And so we can also invite them, if there are no more questions, we can invite the audience to join. So over to you, Jonathan.
Some of the questions are coming in and touching on a lot of the points you all have raised. Ido Akanmu asks, for instance, speaking from my corner in Nigeria, how do we come together as private sector players to sustain pressure on government to increase funding for health and not just be there for emergency bailouts as we witnessed at the peak of the pandemic? Perhaps, Dr. Abasi, maybe you'd like to.
Sure. Thank you, Jonathan. So, do we all come together? I think one of the major issues, and I'm going to piggyback on something Ola said, which was, you cannot dissociate economics from healthcare. And the reason that you have quite a lot of investment in healthcare in more developed parts of the world is because they have big GDPs that they can tax and, put to use within, their countries. And I think that it's not just a solution of looking at healthcare as healthcare in its own silo. In order to improve healthcare, you need to improve the economy, right? You need and one of the things I want to stress on is the fact that we don't do value creation in Africa. We are still at that mindset of raw materials. And that's why we don't have money. We don't have money to do anything because we export all our raw materials. And it's the same thing with healthcare. Tell me how many African companies have actually created a medicine that is sold globally? If you create a medicine sold globally, and even if that medicine was bringing in $1 billion a year, that is up to 20 years of you hold patents to $1 billion a year, just from one drug. $20 billion in 20 years. How many African companies are doing this? None. When you look at China, China was not creating drugs at the beginning, about 20 years ago. Today, they account for 40% of new drugs developed, right? And so you begin to create value, but it's not just in healthcare, it's in, industrials, it's in everything looking at. And I think that until we start creating value in all the various industries that exist, and Africa has lots of raw materials, so why do we not have the funding to take care of our healthcare needs? And so I think it's systemic. I think it's, everybody has a role to play. The healthcare people have their role to play. But I think that everyone here, whether you're in healthcare or in some other vertical, you have a role to play, because the more you're able to create value and give people jobs, and there is money in the economy, then healthcare too can improve. Because to be honest, healthcare is a reflection of the economic situation of a population. And so if you ask me, I think that would be the one thing. Of course, there are smaller things we can all do, and we can say, okay, this is what we do here, let's do this project. But I think that, creating that right ecosystem environment, having the policies, having the right, the individuals in various sectors come back, right? Or don't even come back, but figure a way from where you are to do something that creates value back to the continent. And all of that will increase the pot from which healthcare is funded. Oh, and one more thing, let's see healthcare as something we have to spend to do, right? I remember when, COVID happened and you told people you had to pay about $100 equivalent to do the COVID PCR test. It was a mind shift for many people, because they're like, which diagnostic test costs $100 plus? Because they used to, routine tests that cost $5, $10. And when people can't make that shift, how do you expect to receive the best, right? And so we all need to understand that we have to pay for healthcare, whether it's through government fund or through our own out of pocket or through health insurance, or healthcare needs to be funded, and one key player in healthcare is the payers, and we don't have enough payers for healthcare in Africa.
Jonathan, do you mind if I just pick up on that? Because healthcare financing also is like one of my major areas of, interest and passion. And obviously, the Flying Doctors Healthcare Investment Company is a healthcare financing company. So that's sort of what we do every day. So how do you increase the amounts of funding available in African budgets for healthcare? So first, I'll start with what an African budget looks like. And I'll just give the example of Nigeria, because it's just a sad example, right? So we have a bit of total budget of about $25 billion. And I keep on comparing it to London because it's London School of Economics. So, I compare it to the UK situation. And when I'm trying to explain the Nigerian budget, people don't realize that when the Chancellor of the Exchequer in London comes out and says that this is the budget, the money is complete. He has the money. The problem is how to spend it. When we announce our budget in Nigeria, that is an announcement that we're going to go and start looking for the money. because we're continuously in deficit. So the body is not complete. We have about maybe 10% of the money. And that is when we now go and start looking for who to borrow from the money. But we have about 25 billion budgeted. Almost 70% of that money goes on debt servicing. So that's 70% gone immediately. It's deducted from source, goes back to the foreign creditors that we've borrowed money from in the past. So that leaves us with just 30%. We have over 1 million civil servants. About 90% of the rest of the 30% just goes on paying their salaries. And we have to employ civil servants because these are the people that give you political capital, right? When you win an election, there are people that helped you. They need to be in that civil service for you to win the next election. So it's very important that those people get paid all over, because those unions, those civil servants are the people that you go and lobby during elections. So you can't cut civil servants. So those people need to get paid. So we spend another big chunk of our money, of the 30% left after paying our creditors, on salaries. So then, what does the rest remaining tiny amounts go on? That's what we have to share, and we have to borrow money to get it. So borrow more money, putting ourselves more into debt. So the debt servicing ratio goes up. At the same time, we have this tiny pot of money where the money for healthcare has to come from, the money for education has to come from, the money for infrastructure has to come from, the money for projects has to come from, the money for security has to come from, the money for the army to fight Boko Haram in the north has to come from, ammunition, armor truck, everything that you're using, surveillance, all of those things need to come from that tiny pot of money. So how do we do it? Do we do it by tax? Like I said, tax is always a problem in Africa. I think that Ghana manages to collect about 13% of GDP in tax. Kenya, about 15% as well, maybe slightly more. But nobody manages to collect the figures that we see in the UK and the US, so going 35, 40%, right? Because people are poor. In Nigeria, the average Nigerian spends 70% of their income on food. Don't even take you to the figures in Chad and Mali and Niger and other surrounding countries in Nigeria, because Nigeria, when you compare to those countries, Nigeria looks rich. So if it's very, very, very difficult to get taxable income from people that haven't eaten, and 60% of our population live below the poverty line, and the poverty line is $3,000 per year. So now I've contextualized all that. How can we, with all the problems and all the challenges that I've mentioned, how can we increase healthcare funding? So I think we need to get creative about things. Last year in 2020, Cuba actually made over $15 billion, more than Nigeria makes from oil and gas, from just outsourcing their doctors. So instead of it like the Nigerian situation where doctors just pass PLAB and leave and go and work in the UK or go in America, Cuba actually charges a levy on each doctor. So each doctor that leaves Cuba for another country actually continues contributing to the economy through some sort of compulsory remittance. And that way, even though Cuba continually loses doctors, they're still able to gain from that levy more than we make from oil and gas. So this is a huge source of income. And maybe it doesn't have to be exactly like Cuba. It could be a managed migration program. It could be a training per tract program. But if doctors are getting up and leaving anyway, I think there's a way that we should be able to monetize that. The second is through public-private partnerships, and I spoke about this before, right? Bringing in private capital into the healthcare systems and making sure that, you know, they don't have to, the government no longer has to take on these huge capex expenses to improve healthcare. With private sector capital, the private sector can actually make these investments, and then the government pays over in smaller installments. And you can find donor agencies, you can find, you know, financing authorities that can give very, very low interest loans for healthcare, and so that you don't have to make these huge capex investments and pay over time. The third is through technology, making sure that, you know, we use technology wherever we can to reduce the cost. And, you know, you can use technology to do telementoring, telemedicine, and telementoring is, you know, linking doctors with community healthcare workers. So you still get something that approaches the standard of care without the doctor being physically present, reducing the number of doctors that you actually need in the healthcare system. Training people that are not doctors to be surgeons, because those ones can't leave. They're not certified to practice anywhere else. Training people that are not just to do surgery, to do things that typically doctors won't do under the supervision of a doctor, means that you can increase the healthcare system, but reduce the salaries, which are the major costs for the healthcare system. And I think another thing that people don't really talk about, but is important, is pressure, political pressure. When Anwar Brevin produced the reports for the NHS saying that he wants to do free healthcare in England, actually British people went out to go and buy it. It was the fastest and highest selling policy paper ever written in the UK. People were so excited about it, and that actually placed pressure on the government to actually invest in healthcare and make healthcare free. So it wasn't an entirely benevolent action. It was because they wanted to win the next election, which every politician wants to do, right? So I think that also there's a role of ordinary Africans to continue writing, continue speaking about how healthcare is important, and make it something that can win or lose you an election. Once you put it front and center of a politician's destiny, then obviously they're going to want to invest in it because they need to. And I'll finish with something that Abasi said about know-how. And there's this brilliant talk on YouTube by Professor Hausman at Harvard, and he talks about how development happens and why some countries are not developed and don't have money, and some countries do have money. And he says that his research shows that it all comes down to know-how. Countries that don't have very much know-how, don't know how to make things, tend to not be developed, right? And countries that do know how to make things tend to be developed. So often the same point that Abasi did is that Africans need to learn how to make things if we want to be rich and have more money to fund healthcare. Thank you.
Sadat, if I can just build on what Ola has just said, and many things are within a minute, promise, yeah. So many things. One, there's nothing to be ashamed about poverty. Thank you very much for raising that. We will wear our poverty with pride. And I think the lesson is to just maximize on what we have, the little that we have, use it more efficiently. But again, going back to the role of the private sector, someone recently said that, the public sector must, it's not they should, but they must work with the private sector. If we're, that's one of the most promising avenues for recovery post the pandemic. He said that this is a marriage of convenience, and it's truly a marriage of convenience. Something needs to happen, and policymakers do need to engage with private sector to protect the economic gains of the recent decades, which, as you both say very well, it's a private sector that has driven this. A lot of more than 80% of the populations actually work in all these levels of private sector, from the more small, enterprises to the more larger enterprises. So I think somewhere along this discussion, and we've seen this actually, and in Nigeria, I have to say the pest sector has been the pest sector in many ways. During the pandemic, we've seen private sector come together in Nigeria, to generate funds for the system. And that's in many places that is unheard of, that people just come together, raise the money that is needed. In your case, set up hospitals, and that's the big thing. So for me is, what's the way forward? How do we create this sustainable environment? How do we create, how do you remove the bottlenecks? How do we ensure this commitment, political commitment, institutional commitment, they would enable the private sector to actually come and do what the private sector can do more efficiently, and also therefore releasing the public sector to do what it needs to do. So working together. And so along the way, I would love to hear from you, and I'm sure others in the audience would, what has your challenge? What have been your challenges in engaging with the public sector? Because we know it's not easy. There's a lot of mistrust. Like you said, people say corruption, but it's not always the corruption. It's not always the lack of transparency. These things are, like you said, all health systems at the moment are riddled with all these problems. And actually someone said that even COVID itself is a mystery. And there's still a lot of, there's a lot that we do not know about COVID. And so transparency, the lack of transparency is not just with the African continent, people in the African continent, it's all over. So how do we learn from what is happening now and use what we have gained already, what we have done already to move forward? And so to you, Ola and Abasi, at some point, even if it's not during this discussion, I'd love to hear how that engagement with the public sector has been for you. Thank you.
Thank you very much. A lot of lively comments and questions are still popping up for you guys. So I would hand over to Jonathan to take a couple of questions, or invite audience to take up the space and ask their questions directly to our panelists.
Yeah, fantastic. Lucy, if I could just raise this with you, because you also mentioned that a really big issue in the COVID pandemic is that we're currently battling with other treatable diseases and curable diseases. And Preeti Mohandas asks, whilst COVID-19 is a huge issue, many other problems are directly as a result of scarce resources, such as diarrheal problems. Should energy be focused on community-driven initiatives that focus on infrastructure and the built environment?
Thank you, Jonathan. Obviously, yes. And I know this has already been said by Ola Abasi, that community-driven, local solutions to local problems will need to be, that needs to be the way forward. So prioritizing, again, back to the discussion around prioritizing, and I'm thinking about Ola's 1,000 budget here. I don't know if it was a budget or just a drinks budget. So, how do we get the most out of the limited that we have? And we think about priorities, like I said, we've lost in Kenya during that one period, the country has lost a lot more people, 30,000 plus people to diarrheal diseases. And that's with about 2,000, just slightly over 2,000 to COVID-19. So, but there are low-cost solutions, low-cost and community solutions to deal with things like diarrheal diseases. And it will be strengthening the primary healthcare system. It will be, using community health workers, for instance. The task shifting we're talking about. We should not all be trying to invest in getting the top of the world state doctors and hospitals. It's not possible. Actually, in a country like Kenya, during the COVID-19 period, we've had a series of strikes by healthcare workers because they've not been paid. They don't have enough PPE. They just don't have the equipment. They don't have the necessary resources to operate even at the most basic level in the middle of a pandemic. And then by shutting down hospitals, by doing, we don't have healthcare workers in the system at that point, then, we're going to lose mothers. We're going to lose mothers to birth trauma, things that will be unheard of in many other countries. Diarrheal diseases. Diarrheal diseases is not rocket science, We do not need a huge investment of infrastructure to figure out how to deal with diarrheal diseases. So yes, community-based solutions and priority-based solutions. So it's not us, and as we've all said, it's not just copying everything that is coming from other parts of the world, but really developing solutions or thinking about our own issues and dealing with them. Because unless the base is sorted, this is a pyramid. Unless this base is sorted, the rest of it crumbles. And the base is the primary healthcare system. The base is the community health workers, if that's what we can afford at this point. So, we're not going to buy the drink worth $1,000. With that $1,000, we are going to dig a borehole or just do something that will then impact the whole community. So let's wear our poverty with pride, and just do what we can. I'm not saying maximize on our poverty. Everybody needs to get out of poverty, but to get to that process, healthcare is a minimal. We must, if we don't get healthcare right, we don't get it at all. And with regard to this, just related to that, we have a lot of private sector support towards that, and a lot of initiatives that are working towards the basic things like diarrheal diseases and maternal and child health services, which is good. But again, back to, there's no public people and private people. So we may have a private sector and a public sector, but we're all looking at populace. So let's work together. Let us all work together and let these institutions, governments, create the enabling environment for everyone who wants to support the system to be able to support the system, and let's maximize on that. So yes, community-based solutions or local solutions, but above all, priority or needs-driven interventions, I think is what we need at this point.
Can I just jump in there if possible? So yes, thank you, Lucy, for that. I want you to pose something that might seem like a contradictory thought, and it's the fact that, so I agree with you totally. In a country like Kenya, more than 30,000 people died from diarrheal diseases, and why should you have to die from something like that? But it is also possible that a bunch of people are dying from tertiary diseases, but because there is no data, we can't tell that story, right? And so, for example, we surveyed doctors in Nigeria in the tertiary hospitals, and we asked them, on average, how many times or on a percentage level would you say that you see patients that you can diagnose? And, about half of them saw it between 20%, with some even saying up to 40% of the time. And then the question was, if you can't diagnose the patient, what do you then do? And the response was, well, in some cases, we tell them to go abroad. In some other cases, we treat for symptoms only. And in other cases, we just let them be, right? And so, when you look at the stats now, non-communicable diseases, cancers, cardiovascular disease, diabetes, etc., they are making up to 50% of the disease burdens, right, in many of our countries. And I'd venture to say that they are even more costly to treat, right? So they make up 50% of the disease burden. Imagine what they will be costing our healthcare systems. And for the longest time, we have focused on, infectious diseases. I think that primary care can be brought into the picture, not just for infectious diseases, but also for, the non-communicable diseases, because if you can prevent them, or if you can catch them early and manage them, then you prevent having to get to that point of end-stage liver disease, for example, right, which can come as a result of, hepatitis B or C, and so, I think that there is a whole lot of connectedness, that affects all of us. But one of the major problems I find is, one, the lack of adequate diagnostics, right, to be able to diagnose what exactly somebody is ailing from. And the second thing is lack of adequate treatment, so we've been in this space now for a couple of years, and we started, we engage with pharmaceutical companies and such. And, from my experience working in the pharmaceutical industry of developed countries before coming to Africa, there is a huge night and day gap between what is available in the UK and the US versus what's available in Nigeria or Kenya or Ghana, right? And one of the reasons I find that gap exists is because we don't even have the right business structures to operate to fill in the gap. How many group GPOs or group purchasing organizations do you know in the pharmaceutical sector? None, right? And so why, and this goes back to economics, if I cannot buy product at scale, then I cannot buy product at low cost. And therefore, the end user is paying for my inability to get products at low cost. We need specialty pharmacists, for example, a company that says, I'm going to come in and step into the gap to handle the problem of biologics. Many drugs today are being treated through biologics, right? So what's intravenous injections, for example, the Pfizer vaccines, etc., would be classified as biologics. But because those drugs have unique challenges like, logistics, storage, and sometimes they're costly. But you see that most drugs for cancers and cardiovascular diseases are falling under these categories now. But there is no one who is providing that service. And so those drugs cannot get into the continent. And so we need to start also, smart individuals that we all are, and exposed as we all are, we need to start looking and saying, what are the various things we can do to fill in the gap? Because healthcare operates as an ecosystem, and it's only when there are key players occupying the various spaces in this ecosystem that the ecosystem can be strong. You're only as strong as your weakest link, and in Africa we have so many weak links, and so I see COVID as a ball, into the healthcare sector. You don't have to be, to have studied medicine or be healthcare trained. I like seeing, sometimes there was a time I did this experiment where I went and looked at CEOs of the big healthcare companies globally. And it will surprise you to know that not many of them have medical degrees, or in some cases, even scientific degrees. Moderna, that created, one of the first vaccines, a CEO does not have a medical degree, right? And, why don't we look at this as a call to action? And it's only when we do that and we bring learnings from aviation logistics, and we bring learnings from banking sector, that we can solve the problems of healthcare. Because healthcare is not like most. It's not we are selling and buying and selling a product. It's a combination of solving lots of challenges. You're solving the cost problem. You're solving the availability problem, the compliance problem, the patient management problem. You're looking into the future, the policy. We need all these people coming in, and that's how we make Africa healthcare work. No more should healthcare be the space of medical doctors alone. And that is the major problem we've had. that once upon a time, you had to be a medical doctor to be the head of a hospital or the head of an agency. No, we don't need that anymore. Let's all come together. Let's all bring our unique assets and let's solve the problem together.
Thank you very much to all of you. It's when the conversation gets interesting, that is when you notice that time is not your best ally. It's like we have almost 12 minutes to end our session. And so I will invite Jonathan to just give us the last series of questions, and then we will come back to you to wrap it up. But in wrapping up, I have a big question for all of you in your concluding remarks to consider that in the midst of this recovery, we have seen what is considered as a vaccine apartheid or vaccine nationalism. And this does have greater implications for us in Africa in terms of our road to recovery. And so how do we position ourselves in our recovery to building a more equitable and sustainable future for Africa with this new dynamic that we are confronted with? Over to you, Jonathan, the last set of questions that you have from your side.
I think this question would somehow summarize a lot of the discussion surrounding the private sector and the public sector. And Deji asks about the debate of how much healthcare should be considered an investment versus a public good funded by taxes. So both sources are scarce in Africa, and how do we solve this conundrum and navigate around this private versus public conundrum? Perhaps Dr. Ola Brown, would you like to?
So I actually don't think it's a conundrum. Governments don't have money, so capital has to come from somewhere. We need to get over this idea that the money is being stolen. Like the money is being stolen and there is corruption in African systems. Or even if you look at the total GDP, right, of Nigeria, which is nothing has been stolen from, right? The total GDP of Nigeria is like around $375, I guess, $billion. That is Seattle. So it's obvious that we don't have enough money. When you look at the budget of New York, the budget of New York City is about $100 billion for the city of New York, for a city of 9 million people. Yeah, when I go to New York, the place is still dirty. I still see homeless people. I still see people that don't have access to education, but they have $100 billion. We have about 10 once debt has been deducted, maybe 7. But so how is that going to cater for 201 million people and counting? Like it's a very, very difficult thing, right? So I don't think it's a conundrum. We don't have money. And we need to come to the acceptance phase of that, as Lucy has been saying. Once we have accepted that, then we know that, okay, private sector capital needs to come in. What is the type of private sector and donor capital that we'll now accept? But definitely our governments need help because our economies are not yet productive. Even if you take the whole budget out of Nigeria and, you know, like the UK stimulus package, for instance, which was just money given out to poor people, was $400 billion. That's Nigeria's GDP that they just used to do stimulus one time and forgot about it as if they hadn't spent money. You know, so the differences are huge. That is why we do need, as in, I don't think there's any other option but to look to other sources of capital as our economies grow, as the companies grow, as they are more, as people become more resilient, as people become employed, then they'll be able to pay taxes, which improve the public sector purse. And we can definitely plug the gaps. I mean, there are issues to be tackled around corruption and things like this, but I think it was Efosa Ojoma in his book, Prosperity Paradox. He presents very accurately his research, very sort of articulately, his research that shows that as economic growth increases, corruption decreases automatically. So when there are scarce resources, if you remember that, like Men Who Built America time in American history, you know, things were very corrupt, right? Like they were lobbying governments anyhow, you know, things were not being done properly because the country was still industrializing. But now there are strong institutions. So as economic growth increases, corruption actually decreases. So I think focus needs to be on not if there's a need for private sector capital. I think that's, you know, not debatable because African governments are so poor, but how does that capital get deployed? And how does it produce a win-win for the entrepreneurs and the innovators and the people bringing technology? How can it be exported? Because healthcare is a problem everywhere. Right now, every 20 cents out of every dollar generated in America goes on healthcare. If they continue spending like this, then by 2050, 40 cents out of every dollar go on healthcare. Everybody's healthcare is unsustainable and everybody is battling with problems. What kind of solutions, low-cost solutions developed in Africa and developed in India, be useful to America, be useful to the UK, can be useful to other parts of Europe who are struggling with the same issues, right, of how to fund healthcare. So I think, even in the NHS, there are private sector players in the NHS. In America, there are a lot of private sector players doing great work within the Medicaid and Medicare system. So it's, how do we channel that private sector capital to take the best advantage of the technology, the efficiency, and the capital, the investment, the financial withal that private sector players can add to healthcare systems in Africa.
Thank you. Can we hear from Dr. Abasi? And then we will go back to me.
Yeah, I mean, Dr. Ola said it all. When there is no money in the government, I mean, you have to look for money elsewhere. And you have to look for money and you have to think about how we can create value even in healthcare. Someone put a comment about natural resources and how you can, develop natural resources, create value through that. And therefore, have more of a bargaining power, more economics, as we call it, in my own part of the world, in the product that's being developed. As a company, that is essentially what we set out to do. We set out to create drugs using human genetics-led insights from research we do in Africa, but drugs that can be sold on a global to the global population. And, by so doing, employing tons and tons of Africans and bringing that same value back to the continent and utilizing those relationships with the global pharmaceutical companies that want access to what we might produce to say to them, you have to start taking things back into Africa. Innovation should not just come out, it should also go in. It gives a seat at the table. And if all of us, and it's not easy to do, of course, you have to be able to stand your ground and, don't cheat money and all that type of stuff. But, if all of us did something similar, if we got ourselves to sit at the table, we will be able to direct both funding and innovation back into the African continent, as well as create innovation that can be sent elsewhere. It's interesting. Some of our medical, whether it's our doctors, we've talked about how doctors are being, swooped up every year by foreign countries. But it's even our scientists too, right? And so, we do have the brains, we do have the smarts. So let's start creating, not just for Africa. Yes, we should create for Africa because it makes it cheaper for us, again, because you're cutting out lots of middlemen, you're cutting out logistics and unnecessary costs, right? And so that's why you want to create for yourselves, but you want to also create so that you can also pull in capital and funding from the world. So that's how I see it. And the way I see that this can even begin to happen is, you need to get more people into the healthcare space who are doing innovative work and, get financing, get investments. Investments are key to financing, that can actually help us build these types of businesses that bring value back to us. But in the same way, companies need to start funding health insurance. And health insurance companies should increase how much they charge companies for health insurance, because at the end, if your health insurance product cannot pay for basic health care, is it really a health insurance product? So if you're a health insurance provider in Nigeria, a private health insurance provider in Nigeria or Ghana or wherever, ask yourself, how up to date are your plans? Is it actually relevant to the healthcare issues people are facing in today's world? And if it's not, then you're selling paper. You're not really selling health insurance. So we need to start, we need to begin to challenge each other, so that we all get, to this place where we can all bring value and share the value amongst ourselves.
Thank you very much, Dr. Abasi. Dr. Lucy, conscious of time, we have barely 2 minutes to
all
end.
Right. Thank you.
To put you on the spot with regards to the time, so that we can run this.
No, I think the other speakers have already said as much as I could say about this issue. For me, I think in conclusion, one of the things that I would say is that, whichever angle we take, good health is nature's peacekeeping force. And that's a minimum. We cannot have nothing else will happen until we have good health. And one thing COVID-19 has shown us is a global pandemic. It's been an equalizer. So even the best of the best health systems actually struggled. They struggled a lot than the least, those that are considered the poorer states. And therefore, it's not about the poverty. It's about how we maximize the buck. How we stretch the dollar to get the most out of it. And finally, just with regard to this whole vaccine apartheid, I think it all boils down to communication. For starters, beyond the wider communication issues from the beginning of the pandemic and how we have communicated. I'm conscious, and we are thinking about this as well in the platform, that a lot of communication occurs. Global communication is done in the core WHO languages. For a country like Nigeria, for instance, you have, I don't know how many languages, thousands. In Kenya, with several languages. But we communicate using core languages, and often meaning is lost in translation. So, for example, this pandemics come with new terms. Stay at home, social distancing, wherever. Social distancing, are you saying I don't go see my mother? I don't attend some wedding? I don't, all those things. And this is part of the problems. This is part of the reason why we have all this infodemic, all of this, because I think, especially in the continent where we have multiple language groups, we have not taken the time to translate and validate the messages. So they get lost in, what if we don't do it properly from the onset, then this get lost in the process, and therefore we lose it. And this needs to be sorted to address this vaccine apartheid. And also we need to have leaders, we need to have the leaders, leading from the front, not from behind in a lot of these places. And they need to be the ones communicating the messages around the vaccine, and also, of course, liaising with the champions, community champions, people who can share these messages and make demystify the vaccine, demystify the disease. We've been there with HIV. I'm sure we've been there with Ebola. We've learned a lot, really. We have a lot. We need to just pull the memory that we have had from all this and move on. But for me, ultimately, health, good health, nature's own peacekeeping force. We must keep to that.
Thank you so much. On that concluding note from Dr. Lucy Kanya, and thank you to all our panelists who have shared with us their experience, not just experiences, but very good ideas on how we can build on the systems and things that we already have in Africa to make sure that our route to recovery is one that will make us more successful, so that come 10 years down the line, we will not go back to be having such kind of challenges. Like Dr. Lucy in your opening remarks talked about Africa losing a decade in terms of our development, and so we need to catch up. For me, the big takeaways that I have listening to you guys have been the relationship between economics and healthcare. We can no longer treat them as separate things. We need to look at any dollar or anything we spend on healthcare as being spending as an investment in building our economy. And so that was one of the takeaways. The need for collaboration between the private sector and the public sector, because that has been shown in the response and the recovery to Ebola, and now in COVID times. So we need to build on that on our road to recovery. And of course, the need for us to look at the ecosystem that can support innovation in Africa was one of the key takeaways that I'm also having from this conversation. And I'll not end this without talking about need for homegrown, low-cost solutions that are already out there that we need to build on our road to recovery. And last but not the least, Dr. Ola, you mentioned, and I'm going to repeat it, and Dr. Abasi supported that in terms of funding and innovation. It's about technology, it's about efficiency and the capital of the private sector that we will need to bring on board in this road to recovery. So with these few takeaways from my end, not attempting to summarize all the brilliant points and experience that you have shared, I want to say thank you very much to our speakers for making time to be with us this morning. And thank you very much to our audience. We would have loved to be face-to-face, but we have to do this through the power of technology. And so thank you for your patience and for being with us this morning. Thank you. Enjoy the rest of the summit, and hopefully we can keep the conversation going on as we look at the road to recovery for Africa. Thank you once again. Thank you very much.
On note, I'd like to thank the speakers one more time. Thank you, Dr. Lucy, Dr. Ola, Dr. Abasi. Also, thank you to Sadat for moderating the session and for synthesizing everything at the end here. On that note, I'd like to extend thank you again on behalf of the organizing team, and just quickly would like to say to all attendees that the next session is to meet other participants as well, and you can do that in the lounge, and we will also have a career fair which is taking place in the arena. So please get involved, and we'd love to hear your reflections as well. Thank you again.